Good morning, welcome to In the Trenches with David Cohen. I haven't made a YouTube video before, but we're on the comeback trail. Today's topic is hyponatremia. This is a very long topic. I'm just going to go over some highlights with this. The issue with hyponatremia, it is a very common electrolyte abnormality we see in hospitalized patients, and you need to have an appropriate approach to hyponatremia. Now, the thing with hyponatremia, when you worry about it, it's the level of the sodium and the rapidity of decline. So if the sodium is low and it gets there quickly, it's more serious. So basically, you have the blood and you have the brain. And if the blood acutely drops the sodium, the brain does not have time to dissipate idiogenic osmoles or osmolytes, and you will get cerebral edema. Now, the people of mild hyponatremia or chronically hyponatremic, and they could actually also, this is the opposite spectrum, have a little bit of cerebral edema, and these people are chronically like that. It's almost the equivalent of having an alcohol level between 60 and 80 in your brain. Okay, that's the acuity. The next point, and the most important point that you need to know, for most cases of hyponatremia, you cannot dilute the urine. There's a problem diluting. So the urine sodium, okay, is the sodium over free water. It's the sodium over free water, okay? And if you can't dilute the urine, okay, you can't put free water in the sodium. Urine osmolality is usually, but not always, higher than it should be. That's a very, very important point. Now, the major player involved with hyponatremia is ADH, or vasopressin. And here it works in the collecting duct of the kidney. It opens up aquaporin channels and causes resorption of free water. So let's talk about how you approach hyponatremia. Okay, there's a phenomenon called pseudohyponatremia. It's associated with very high proteins like Waldenstrom's macroglobulinemia or very high triglycerides. This is not a common thing. I don't want to spend time on that. There's also hyponatremia associated with increased osmolality. Most cases, just about all cases of hyponatremia, you have decreased osmolality because the sodium's low, and the formula for osmolality is 2 times the sodium plus the glucose over 18 plus the BUN over 2.8. Here you have increased osmolality. It's seen with elevated glucoses. And what's the correction factor? The classic correction factor is your glucose goes up 100, your sodium goes down 1.6. There's some newer data that maybe the correction factors too. But if you have somebody coming in with an uncontrolled diabetes state like HHNK or DKA or just severe hyperglycemia and their sodium's low, you make the correction factor first, and that's usually obvious. Okay, then what do you do after this? Okay, you basically are going to divide it into volume. So you have decrease effective arterial blood volume, decrease ECF rather, increase ECF, and normal ECF. So here you're going to lose sodium and water. You're just going to lose more sodium than free water. Here you're going to gain sodium and free water. You're just going to gain more free water than sodium. And here you're just going to gain free water and not sodium. That's normal ECF. Okay, going through this. So if you're losing sodium, you're going to lose it 2 ways, either from the GI tract or the GU tract. GI tract, vomiting or diarrhea. GU tract, the most common cause involved in thiazide diuretics. And so many times thiazide diuretics will cause low sodium. You could also have primary adrenal insufficiency, Addison's disease, not common, but it exists, or sodium losing nephropathy, not common either. Okay, but the mechanism of hyponatremia, you have decreased effective arterial blood volume, and this basically is going to stimulate neurohormones, and you're going to have ADH stimulated appropriately, and the ADH is going to cause that. Now, with increased ECF, that's classically CHF or cirrhosis of the liver, maybe nephrotic syndrome. It's really the same mechanism, okay? With CHF, you have decreased effective arterial blood volume, and the body senses you as being dry, and ADH is released appropriately. With cirrhosis, you have profound vasodilatation, and the body senses a decreased ECF. And these things you see with severe heart failure, okay, and severe cirrhosis. Now, what about a normal ECF? We have SIADH, okay, and the whole spectrum of all this. We have tea and toast, which is water intoxication, thiazide diuretics, and sometimes that's combined with tea and toast, psychogenic polydipsia. And then there are other things that do this, but since this is a brief video, these are often the common things. Last thing I want to talk about in this video, and I'm going to do another next week, I will do another hyponatremia, I will continue this, okay, is what tests you get, okay? And there are three tests that, in my opinion, are important. The urine sodium, urine osmolality, and serum uric acid. These are the three biggies. Urine sodium, you know, if you have GI loss or renal loss and you're not on the diuretic, your urine sodium is going to be under 10. It's going to tell you your volume depleted. Theoretically, severe CHF and severe cirrhosis, okay, provided you're not on diuretic, they're going to resorb sodium proximally, okay? Serum, with SIADH, you're resorbing free water. Your urine sodium is not going to be low. Okay, it's not going to be low with SIADH. It's not going to be low with anything where you're resorbing free water. The urine osmolality is important, but you have to understand there's no normal range of urine osmolality. So normal urine osmolality could be as low as 50 in a young person, and an older person probably as low as 100. Okay, but if your serum osmolality, if your urine osmolality is greater than 50 to 100 and you're hyponatremic, you're having trouble diluting the urine. So you could have one patient, okay, who's got a urine osmolality 230, and you're going to say, well, the serum urine osmolality is less than the serum osmolality. It doesn't matter. They're not diluting the urine. They're not diluting the urine appropriately. And that's that's also very important for treatment. This is a very important test. The serum osmolality really isn't important. Its only use is really if you're trying to make a diagnosis of pseudo-hyponatremia. The uric acid level is very important. I'll tell you why. SIADH is on the differential of all this stuff. And with SIADH, you actually have increased fluid. Now, you don't have edema. You do not have edema. With SIADH, you can't have any cardiac, renal, adrenal, pituitary, hepatic, or thyroid dysfunction, or cardiac dysfunction. But these people are releasing ADH, and you get about 2 to 3 liters of excess fluid. So these patients are somewhat volume level, but they're not edematous. But unlike the other causes, they have slightly increased effective arterial blood volume. Okay, and their GFR is increased a little bit. Okay, so uric acid, it works from the kidneys in 3 places. It's resorbed proximally, then secreted, then resorbed distally. But here, your GFR is so high that you're not going to resorb uric acid proximally. You're going to wash it out. It's the opposite of dehydration. Okay, likewise, these people have very low BUNs. It's the same reason. You're dehydrated, your BUN's up. You know, your GFR's increased, your BUN could be a little bit down. And uric acid, if it's low, okay, that's a very good clue that the patient could have SAADH. And with this, I'm going to stop. This will be continued. Thank you.